Today I am presenting musculoskeletal compartment syndrome. There is acute and chronic. I will be just touching acute because chronic is a different topic. It is common in athletes and all these things. So, have you come across compartment syndrome, anybody, in their medical career? No. Yeah, it's rare, but it's like, it's something, which you should be very vigilant, you should not be missed. Okay. There's a clinical scenario, 53 years old lady admitted under medical team for investigation of ascites. She had adnexal mass and she underwent bone marrow biopsy from posterior superior iliac spine. 6 days later, she developed foot drop. What happened to her? Sciatic nerve. She got hematoma in the back, she got gluteal compartment syndrome, and then there was a foot drop, sciatic nerve palsy. So I will be discussing definition, historical background, etiology, pathophysiology, pathoanatomy, clinical features, imaging, compartment pressure measurement, treatment options and complications. Compartment syndrome. What is compartment syndrome? Do you have any idea what is compartment syndrome?
Closed cavity pressure ज़्यादा हो जाए, तो this is called the compartment syndrome. Compartment बन गया जो है नहीं.
Yes. So when the compartment pressure increase to such an extent that the microcirculation of the tissues in the compartment is diminished, that's called compartment syndrome. Okay. Compartment syndrome, a condition in which a closed compartment pressure increases to such an extent that the microcirculation of the tissue in that compartment is diminished. Raised pressure within a closed space with the potential to cause irreversible damage to the contents of the closed space. Incidence. Margaret McQueen, she did a lot of work on compartment syndrome. She has more than 20 publications only on compartment syndrome. And she is one of the pioneer in the work. So she, according to her different studies, 7.3 per 1 lakh man, 100,000 man, it is common, and 0.7 in women. But male to female ratio is 10:1, so more common in male. Most common cause is tibial shaft fracture and then the forearm fracture. 1/4 of the cases in trauma, there is no fracture, but still they can have compartment syndrome, like 1/4 of the cases. And highest prevalence is in young age group, like from 12 to 19. The most common site is leg, and then forearm, which is followed by arm, hand, thigh, gluteal region, foot and abdomen. In ICU, did you come across any abdominal compartment syndrome? Yeah, so it is common in ICU patients. In historical background, Richard Walkman, he was one of the, he was a German orthopedic consultant and he was a lead physician of German military. So he did a lot of work initially in on compartment syndrome. So he mentioned that the bandage is too tight applied, the occurrence of paralysis and contraction of the limb, not due to the paralysis of the nerve by pressure, but as quick and massive disintegration of the contractile substance and the effect of the ensuing reaction and regeneration. So basically he mentioned that it is not the nerve which is causing paralysis, it is the muscles which are getting damaged due to the compartment syndrome. Hybrid, later he mentioned a term Walkman ischemic contracture, which is the endpoint of compartment syndrome. So if you see here, this is the limb here. The limb is flexed, fingers are flexed, they are stiff, they are unable to extend. The muscles here, they are dead. So there is a flexion contracture. So this is called Walkman ischemic contracture. So this is the sequelae of compartment syndrome. If you miss compartment syndrome, this can happen. Walkman's contracture, mostly it is like in our part of the world, these bone settlers, what happened, they find the fracture and they just start bending, tight bandage. It compromises the circulation, there is no space to expand, they get compartment syndrome. So supracondylar fracture, brachial artery damage, blood flow decrease, ischemia, persist for a long time, necrosis of the muscles and develop ischemic contractures. This is another picture of a Walkman ischemic contracture. Here the limb is also short. Left upper limb is also short. Why it is short now? Muscle necrosis हो गई, लेकिन bone क्यों short हो गई? When he developed compartment syndrome, the bone circulation was also affected. So growth plate जो है वो affect हो जाती है. तो उसकी जो growth है वो generally जो affect हो जाती है. Mr. Murphy, he mentioned like tight bandage aided by the tight skin and fascia that does the mischief. He used the word mischief about the tight bandages. He was the first to suggest that fasciotomy done under early might prevent contractures from the developing. He was the first who started fasciotomy. Then Seddon, Kelly and Whitesides in 1966 and 67, they have mentioned that you need to decompress not one compartment, you have to decompress more than one compartment. So most common it is in the leg, and in leg there is 4 compartments. So basic anatomy, what are those 4 compartments? Posterior, superficial and posterior deep. So when you are decompressing it, you have to decompress all 4 compartments. So the causes of compartment syndrome, most common cause is fracture, like in trauma, then soft tissue crush injury, vascular injury, burns. Here you can see the picture of a burn. What happened, when there is a 3rd degree burn, the skin is it is all necrosed. There is no expansion capacity in that. And then due to that injury, the muscles, when they start, due to edema, they start swelling. There is no place to swell. So they develop compartment syndrome. I am not sure whether you were there in the ED or not. There was a patient with electric shock. Well, you were not there. I just saw like a week back. There was a patient came from, he got electric shock. Electric entry was in the hand and exit from the other hand, and this arm was completely like swollen, tender, and he had compartment syndrome, but they were just rushing patient to Nishtara, so we said it's fine, but you need to decompress as soon as possible. Tight casts, tight bandages, extravasation, iatrogenic, extravasation IV infusions. If you missed it and they are extravasating, it can cause compartment syndrome, particularly in the hand and the feet. Prolonged lithotomy position, most common maybe in gynaes, but they are not prolonged procedures. But if somebody is prolonged in lithotomy position, the vessels are compressed. There is ischemia in the leg, and there is gradually edema, and then the vicious cycle starts. Should, like, I don't know exactly, but you have to see, you have to when you are positioning, you have to just to make sure that the vascularity of the foot is not compromised. Sometimes, when there is a compression here on the popliteal fossa, so the vascularity of the foot, you have to see the circulation and perfusion. So that should be well padded, and there should be no pressure on the popliteal fossa. And then if the limb is like in this position, it is above the heart level, the circulation is the flow is already less because it is against gravity, and when there is a pressure on the vessels, it will further aggravate the circulation. So if somebody has underlying coagulopathies, even some injections they can cause hematomas, and they can have compartment syndrome. Reperfusion injuries. What is reperfusion injury? It is basically if somebody has a vascular injury and the vascular surgeon did the revascularization. So the tissues distal to that revascularization, they were like anoxic. When they were revascularized, the tissues were not completely dead, but maybe some of the tissues were dead. When they are revascularized, they got edematous in the limbs, and they can cause compartment syndrome. So what the vascular surgeons do, they do prophylactic fasciotomies. Even after revascularization, they do the fasciotomy to prevent this reperfusion injury. Reperfusion injury is lethal because the tissues are dead. When the blood circulation comes in, all the toxic things, they come in the bloodstream, like potassium particularly. They can go into hyperkalemia, acute kidney injury, and they went into shock. Snake bite. Snake bite, there are different types of snakes. I won't go in details, but we read in forensic medicine, there are some which are neurotoxic and some are vasculotoxic in coagulopathy. So these coagulopathic, they can cause bleeding in the limbs and cause compartment syndromes. I come across during my residency in AIinHealthCare, it was not a snake bite, but it was some insect bite. Patient came with the massive swelling in the arm, and we have to do the fasciotomy. So pathophysiology: increased tissue pressure, ischemia, irreversible muscle damage. Common pathways towards the cellular anoxia, interaction between the compartmental pressure, blood pressure and blood flow. So we will discuss in the subsequent slides. So arteriovenous gradient theory is the local blood flow drops. So whenever there is an injury in the limbs, there could be some vasospasm or maybe some partial injury in the vessels, or not in the major vessel but in the collateral vessels. The local blood flow drops that lead to metabolical demand of the tissue is not met. So there is some ischemia, compartment pressure start rising, venous pressure rises, so there will be reduced venous flow. So there will be when the venous flow is less, there will be venous congestion, and then the limb start getting swelling. It further reduce blood flow and decrease perfusion. So it is a vicious circle. But autoregulatory mechanism, they also start working, decrease in the peripheral vascular resistance, increased extraction of the oxygen. But a time comes when the system is completely overwhelmed. They are not getting the demand of oxygen. So critical closing pressure is reached and oxygen perfusion of the muscles and nerves decreases, and then the tissue necrosis starts. Originally thought that the threshold pressure or the absolute pressure beyond which irreversible changes occurs. There was initially thought that when the pressure to such extent reached, there is a muscle necrosis or compartment syndrome. But then the subsequent, I mentioned like Margaret McQueen, she mentioned that delta pressure is more important than the absolute pressure. For example, if the compartment pressure is 50, but there is a possibility this patient may not be compartment syndrome, because if the diastolic pressure is already 100, so in the system the blood pressure is high, the systemic pressure is high. But if someone has diastolic pressure is low, like for example 50, and the compartment pressure is 45, so the difference is less than 20. So that is significant. So if there is a difference, delta pressure is difference between the compartment pressure and the diastolic blood pressure. If it is less than 20, it is significant. Normal tissue pressure is 0 to 4, but with exertion it go up to 10 millimeter of mercury. Absolute pressure could be 30, could be 45, but pressure gradient theory by Margaret McQueen shows that if if the difference between the diastolic and the compartment pressure is less than 20, it is significant, and that's called delta pressure. So up to 4 hours damage potentially reversible, but after 8 hours it is irreversible damage. If some patient is coming like with the compartment syndrome established after 8 hours, probably we have missed the boat. But still, like sometimes we do fasciotomies to see whether there is, how much there is necrosis. But if somebody is coming like after 1 day ischemia, like, or 2 days, then what happened? If you release the pressures, the muscles are all dead. Now you have exposed the muscles to environment, dead muscles. So it is now, it will go up, end up in amputation, otherwise he will be died. So if somebody is coming with the compartment syndrome more than 24 hours, you have already missed the boat. So now you don't do fasciotomy. Let everything in closed compartment. At least they are not infective. Alcoholic acidosis, hyperkalemia, arrhythmias, shock, and can lead to death. So it is not like endanger the limb only, it can endanger the life as well. And the vicious circle, cellular death, increased capillary permeability, increased muscle swelling lead to increased compartment pressure, and then further reduce muscle anoxia and increased capillary permeability. So this vicious circle continues till the death of the muscles. So presentation and diagnosis. So how they present, basically, the guys with the compartment syndrome, how will they present? Dr. Abdullah.
There will be paresthesias or coldness in that leg. जब वो हिस्ट्री देगा कि पहले मुझे फ्रैक्चर हुआ था, उसके बाद फिर अब ये जगह है यहाँ पे लीडर्स एंड पेन्स हो रही हैं, ठंडी हो गई है, और
The first and most important thing is pain. Pain out of proportion. चीखें मार रहा होगा, आप कुछ भी दे दें उसको, उसका पेन सेटल नहीं होगा अनलेस कि वो सेडेट हो जाए. इतना आप उसको मॉर्फिन दें कि वो सेडेट हो जाएगा, फिर तो शायद वो पेन कंप्लेन ना करे. लेकिन जब तक जाग रहा है, पेन विल नेवर सेटल. पेन डिसप्रोपोर्शनेट, पेन आउट ऑफ प्रोपोर्शन, ये फर्स्ट थिंग है. ठीक है. अच्छा, हाई इंडेक्स ऑफ सस्पिशन ये है कि यंग एज पेशेंट हो, एथलीट्स हों. मैकेनिज्म ऑफ इंजरी क्या है? इफ़ इट इज़ हाई एनर्जी ट्रॉमा, they can lead to then snake bites, insect bites, underlying medical conditions. अगर minor trauma भी हुआ है और patient जो है वो anticoagulants पे है, तो उसको he can get a big hematoma. Disproportionate pain and passive stretch of the compartment. आप किसी भी मसल्स को पैसिवली स्ट्रेच करें, एंकल को डॉर्सीफ्लेक्स करें, अगर पोस्टीरियर कंपार्टमेंट में है तो पेशेंट चीख मारेगा, तो आपको हाथ भी नहीं लगाने देगा. पेन आउट ऑफ प्रोपोर्शन, palpably tense compartment, swollen like a wooden calf, बिल्कुल टाइट वुड की तरह सॉलिड हो जाता है. पेन विद पैसिव स्ट्रेच, पैरेस्थीसिया, हाइपोस्थीसिया. अगर किसी को पैरेस्थीसिया, इफ समबडी इज डेवलपिंग पैरेस्थीसिया, हाइपोस्थीसिया और पैरालिसिस और पल्सनेस, it means you are getting too late. So the first thing which start like is the muscles and the nerves, and then you go to the pulses. Now, particularly in post-op patients, I come across, we did a nailing of a patient, and in the recovery patient developed compartment syndrome. Patient did not have compartment syndrome before surgery, but after surgery developed compartment syndrome. So if this patient had epidural analgesia, he will not feel pain and the leg will die. So अगर किसी को limbs का fracture हो, तो we should not give regional blocks or epidural analgesia, and be aware controlled IV opiate analgesia. If you are giving too much, patient will be sedated and he will not be complaining of pain. Diagnosis, these clinical findings, they are sensitive, but their sensitivity is around 19%, but they are specific tests. पेन आउट ऑफ प्रोपोर्शन किसी को भी हो सकता है, लेकिन अगर किसी को इंजरी के साथ हो रहा है तो फिर ये स्पेसिफिक हो गया उसमें. All signs better to exclude rather than confirm. With one signs, the diagnosis sensitivity is 26%, but with 3 signs, it is 93%. So should not wait for the muscles to die, because it will be too late then. There are other differential diagnoses of these symptoms. Arterial occlusion, ischemic pain. Have anybody come across ischemic pain in the leg? It is severe pain. अगर किसी के आर्टीरियल एम्बोलस हो जाए, बहुत सीवियर पेन होता है, क्योंकि स्कीमिक पेन होता है वो. तो उसमें यू हैव टू सी वेदर इट इज़ कंपार्टमेंट सिंड्रोम, बिकॉज इन स्कीमिया, arterial ischemia, there will be no swelling in the leg. It will be just pale leg, but pain is up. Clinical signs and or compartment pressure monitoring. So diagnosis mainly is clinical, but if you have a suspicion, then you go for the compartment monitoring. I will explain in the subsequent which patient needs compartment pressure monitoring. So first of all, if you are not sure whether it is compartment syndrome or not, then you can do the compartment monitor. Like equivocal signs, it may or may not. It is a clinical adjunct, but if you are completely sure that it is compartment syndrome, then there is no need to monitor the compartment pressure. So in ICU, if somebody is sedated or intubated, and if he develops compartment syndrome, he will not complain about pain. There, you can do the compartment pressure monitor. There are different instruments used, but currently the most popular is striker pressure monitor. These were used previously, the traditional tubing system. This is a Synthes digital monitor. I haven't used this one. Even I haven't seen this one. But this is common. It is used. In fact, this picture, I took this picture in Ireland. We did forearm fasciotomy. So measurements must be made in all compartments. Anterior and deep posterior are usually highest. Measurement made within 5 cm of the fracture. अब जैसे दूर चले, if you are going away from the fracture site, the compartment pressure will be less. So it should be within 5 cm of the fracture site. And marginal readings must be followed with repeat physical exam and repeat compartment pressure measurements. Anatomy, there are 4 compartments we already discussed. So anterior compartment, there are the muscles in the anterior compartment. We don't go in details. The nerves for the anterior compartment and the function. So you have to check all these things if you are suspecting that particular compartment pressure or compartment syndrome in particular compartment. Lateral compartment, superficial posterior. This one is the superficial posterior, soleus and gastroc, and the deep posterior is here. So this is the graph, is showing. This is the fracture site, and this is within 5 cm. So the pressure is highest at the fracture site and within 5 cm. So it is recommended to measure the pressure within 5 cm of the fracture site. This slide we already discussed is the repetition. Delta pressure, diastolic pressure minus intracompartmental pressure, and delta pressure less than 20 suggestive of compartment syndrome. We already discussed. So here, if patient is unconscious or the exam is inconclusive, then you can do the compartment measurement. So what is the medical management of compartment syndrome? So yes, they definitely need fasciotomy, but you can start like high oxygen, ensure patient is normotensive, and as hypotension reduces perfusion pressure as facilitates further tissue injury. Remove circumferential bandages and cast, maintain the limb at the level of the heart, as elevation reduces the arterial inflow and the AV pressure gradient on which perfusion depends, and gives supplemental oxygen. So if you are suspecting compartment syndrome in a patient with the cast, take the cast off completely, even up to the cotton. So there's different studies which mention that compartment pressure falls by 30% when the cast is split on one side, and when it is split on both sides, 65% pressure reduced, and then the underlying bandage is removed, further 10% is reduced. Total of 80 to 90% reduction by just taking off the plaster. So if somebody has you are suspecting compartment syndrome with the cast, so take the complete cast off, because you have to save the limb. You can manage the fracture later on, but now the limb is in danger. Fasciotomy is only effective form of decompression, right? And all compartments should be decompressed. There are different fasciotomy or incisions: single incision, two incisions. These are for the leg. So the gold standard is two incision technique. Make early diagnosis, long extensile incision, बहुत छोटे-छोटे incision नहीं देने, big slashes, big incisions, decompress the facial compartment, preserve neurovascular structures, debride the necrotic tissue. अगर आपको नज़र आ रहा है कि tissue dead हो गया, you have to take them off, and coverage within 7 to 10 days. You have to take the patient back to the theatre after 48 hours. There is a possibility that the tissue which was not looking dead at the first visit might be looking dead after 48 hours. So you have to take them off. You can't keep the dead tissue in the leg. And then you have to, once the acute compartment thing is over, then you have to make a plan to coverage closure. If it is, you are not able to close it, then you have to ask the plastics, for soft tissue coverage, either the skin grafting. So this is the two incision technique. Here we can see there is a fibula here, there is a tibia in the front. So halfway between tibia and fibula you make an incision, and this is the lateral incision. From the lateral incision you can decompress the lateral and the anterior compartment, and on the medial side you will be decompressing the superficial, posterior, and the superficial and the deep posterior. So you have to release all the fascia as well. So these are the incisions. Posteriorly you are releasing, this is the posterior incision, posterior medial incision, releasing the deep posterior and the superficial posterior. From the anterior lateral incision, anterior compartment and the lateral compartment. जब आपने lateral compartment खोला तो you will see this intermuscular septum here, anteriorly anterior compartment, here the lateral compartment. You just make an H incisions, दोनों को आपस में मिलाएं और ये fascia और पूरा ये fascia भी खोल दें. This is the forearm fasciotomy. This is my clinical picture. So this was a boy like 14 years old. He had a forearm fracture. We reduced it and put a cast. 14 years old. So should not be doing in 14 years old casting. Like if somebody has a forearm fracture, we should fix it, because it is very difficult to hold the radius and ulna fracture with a cast. Anyway, the cast, we did the cast, but the cast, he got swelling and he developed compartment syndrome. So we have to, this was like 5 a.m. in the morning. We did the fasciotomy. So we have to release the compartment, carpal tunnel here as well. And this is the dorsal incision, and these are the incision on the hand. For these incisions, you don't always need to do this. If there is compartment syndrome in the hand, then you can release the hand as well, otherwise no need. These are the forearm fasciotomy. There are 3 compartments you have to release: volar, like on the volar side, dorsal side. So this is the volar, this is dorsal, and this is the mobile wide on the lateral side here, brachioradialis. So foot fasciotomy, there are 9 compartments you have to release through 3 incisions, 2 on the dorsum and 1 on the medial side. If you diagnose compartment syndrome and if you are not doing the fasciotomy, the muscle will get dead and the patient will develop a clawing in the foot, like a Walkman ischemic contracture in the hand. Another thing, if somebody has a fracture and compartment syndrome, release the compartment, then you have to fix the bone as well. You can't keep the bone. So mostly, what we do the external fixator rather than nailing, because now the wound is open. If the metal is inside, it can get infected. So do the external fixator. Once you close the skin, then either you can treat it with the external fixator or change it to a nailing. So what you will do with the wounds? So there are different techniques. Either you can close it. You will keep the wounds open for 4 to 7 days at least. When you start closing it, either you can do it in a stage procedure or do like bootlace technique. This I will show. I think this was a bootlace. You can see here. This is the elastic loops. They are closing the skin gradually with the elastic mechanism, or you can do split thickness skin grafts. So this is a reconstructive ladder for soft tissue wound managements. Either you can leave it and don't do anything, they will heal with the granulation tissue with a very bad scar, or you can close it after the injury, but here we can't close it immediately after the skin incision or closure. You can do delay primary closure, like you can take the patient to the theater after a few days and close it, but it is difficult to close it because there is a large gapping wounds. Either you can use that bootlace technique or use a skin graft. So these are not for this here. These are for another, for other soft tissue things. So what are the complications of fasciotomy, like surgery? Bleeding हो सकती है. Fracture site. अच्छा, इसमें 2 चीज़ें हैं. कंपार्टमेंट सिंड्रोम की कॉम्प्लिकेशन क्या है, fasciotomy की कॉम्प्लिकेशन. fasciotomy तो हमने कर दी, लिम्ब को सेव कर दिया, लेकिन उसके अपने भी मसले मसाइल हैं. ठीक है. सो अल्टर्ड सेंसेशन विद इन द मार्जिन ऑफ द वुंड. आपने बिल्कुल सारी नर्व्स उसकी काट दी, जो स्मॉल हेयर लाइन जो एक नेटवर्क था स्किन के नीचे, वो सब कट गया. तो अब जो है ही विल फील पैरेस्थीसिया और अल्टर्ड सेंसेशन अराउंड द वुंड. हाँ, yeah, scarring. हाँ. इसमें जो limbs है, here recommendation is to make the incision longitudinal. We can't make transverse incisions here. Yeah. But for the limb, unfortunately, we need a good exposure to the whole bone. With one transverse incision, we can't reach here and here. So we have to do longitudinal. But when we are crossing the joint, so then we have to make a transverse limb and then go down. Yeah. They can have dry skin, they can have pruritus, discolored wounds, swollen limb, tethered scars, recurrent ulcerations, मसल herniations, क्योंकि आपने फेशिया उसका खोल दिया है तो मसल्स जो है वो बिल्कुल स्किन के नीचे आ जाते हैं. Pain related to the wounds, tethered tendons, complications of compartment syndrome. We discussed Walkman ischemic contractures, neurological deficit, infections, chronic pain, amputation and death. So we discussed a clinical scenario in the first slide, that there was a lady with ascites and adnexal mass. She had a bone marrow biopsy done from the posterior superior iliac spine. So what happened to her? This was a case report in our unit when we were working there. So she developed, if you see here in the CT scan here, there's a hematoma in the gluteal region, just posterior to the femur. So there will be pressure on the sciatic nerve here, and she developed sciatic nerve palsy due to hematoma and gluteal compartment syndrome. This is my article in Advances in Orthopedics review article. If you get time, you can. This is a summarized this about compartment syndrome. So there should be highest index of suspicion for compartment syndrome and treat early. Compartment measurement should be judicial. If you need it, you need it. Otherwise, clinical judgment is most important. And fasciotomy is safe and reliable treatment. Any questions?
Sir, if we use